Welcome, everyone. I'm Dick Deming. I'm Medical Director of Mercy Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. Tonight, our topic is surgical oncology, and my guest is my colleague and my friend, Dr. Viet Le. Welcome, Viet.
Thanks for having me.
So, first question, what the heck is a surgical oncologist?
Well, I guess to be full transparent to our audience, I believe tonight meeting was really for my partner, Dr. Franko.
Yes. So we are blessed to have two surgical oncologists at Mercy Cancer Center. And
But
Dr. Franko got called out of town.
Yeah.
So thank you for filling in.
Yeah. So hopefully I can do as good of a job as he could do.
So before you answer my first question, tell us a little bit about yourself.
Yeah.
Where did you grow up? When did you come to Iowa?
Yeah. I don't know if you recall, but we have the exact same meeting 3 years ago.
3 years ago.
3 years ago.
You had just
And
arrived, I think.
I arrived about 1 year
Okay.
before that. And I think in that episode, we discussed a lot about me.
Mhm.
So I'm trying to get you more hits here, okay? More viewers.
So yes,
for
you
our
can-
audience,
they can watch the rerun
yes.
of when you were last here 3 years ago.
Yeah. But brief introductions. My name is Viet Le. I enjoy working with Dr. Deming every single day. I'm a surgical oncologist at MercyOne in Des Moines. To answer your questions, what is a surgical oncologist? We touched on that topic last time. And there's multiple different definitions endorsed by our society. But in summary, it really is a surgeon who is well-versed and fluent in the science and art of multidisciplinary cancer care. And in my opinion, should also be skillful and has the expertise in providing care for solid tumors, including multiple disease sites.
Mhm.
So in my opinion, that would be the encompassing definition.
And there's an important point there that you're not just a surgeon, but you're very knowledgeable about oncology and not just the surgery, which you do, but you're also very knowledgeable about radiation oncology and medical oncology. And in your training, obviously you went to medical school and then a full general surgery residency and then a fellowship in surgical oncology. What does the surgical oncology fellowship encompass? And where did you do your surgical?
Surgical oncology fellowships encompass training in multiple disease sites. So we would have rotations in hepatobiliary system, upper GI tract, the endocrine organ system, the breast, and the lower GI tract, colon and rectum, including the anus, as well as soft tissue malignancy. And also in the last, I would say, 20 plus year or so, we gained an understanding of how cancer metastasizes. And one of those areas of metastasis is the peritoneal surface, which is the lining of the abdominal cavity. And because we have gained more understanding of it, we have cancer-directed treatment for it. And so then the treatment spectrum increased from localized disease to regional disease. And in our society, there's a push for advanced cancer therapy where we can deliver surgical directed treatment in a regional fashions, including multiple different type of modalities.
And where did you do your general surgery and training, and where did you do your surgical oncology training?
Yeah, I grew up in the Southeast, and I went to medical school in Georgia, and I decided to do my general surgery residency in South Carolina. So I spent a good bit of my time in the upstate of South Carolina and around the Southeast area. And I then went on to did my surgical oncology fellowships out in California at the City of Hope Cancer Center. And then after that, I came and joined you.
Yeah.
And I think last time you mentioned that, you've been in the East Coast, you've been in the West Coast, now you're in the Middle Coast. So I still tell my friends that to this day.
So I've been here for 35 and a half years, and I hope we can keep you busy for another 32 years. Yeah. So the general surgery gives you a good skill set in terms of how to do the technical things of cutting and sewing and putting things back together. Your surgical oncology gives you also then a deep understanding of the pathophysiology, how cancer spreads, and all of the different treatments of cancer, not just surgery. But we rely on surgical oncologists when it gets to some of the really tough surgical cases. So let's talk about one, so maybe the audience can get a feel for how you're integrated into the cancer center. So one of the areas that you are proficient at is pancreas cancer, a very complex surgical procedure, but it's also a very complex cancer diagnosis that is definitely requires multidisciplinary, meaning surgery, radiation, chemotherapy. Our pathologists, our gastroenterologists, our diagnostic radiologists. So let's talk a bit about pancreas cancer. So let's take a case where someone presents with abdominal pain and they've turned yellow, so jaundice, and they get a scan, and the scan shows that there is a tumor in the head of the pancreas and it's blocking the bile duct, and that's why they become jaundice. At what point do you get involved in a case like this, and maybe walk us through how we do a multidisciplinary approach to someone with pancreas cancer?
Yeah, I think I think the case you presented is very classical in terms of how patients present. But pancreas cancer also presents in other way as well. If we look at it from a 20,000 feet view, let's start with that. Roughly about 60,000 Americans get diagnosed with pancreas cancer per year, give or take. And even though it's not one of the more common cancer diagnoses, as you mentioned, the treatment and the diagnosis, the staging, and the treatment of pancreas cancer, I do think we have rooms to improve. And because of that, pancreas cancer is the third cancer-related cause of death currently. And it's projected, somber in statistics, but it's actually projected to be the second cancer-related death in the coming years. So, as you mentioned, it's an area that I do think for all cancer specialists to improve on. The reason why pancreas cancer is such a deadly disease is because of anatomically where it's at. So if you look at the human body, and if you split it in the middle, whether side to side or top to bottom, the pancreas is actually right in the center of our body. And so it's in such a anatomically difficult to access location.
And there's lots of important structures that
And
are right next to it. Big
Right.
blood vessels and
right.
nerves and bowel and
Right. And so, what I've learned in my general surgical training from, one of my prior chair was that for us, that's the surgical soul. We define that as the soul, the
soul.
surgical soul,
Okay.
just because of it's around many, many critical important structures. So the case, go back to the case you presented about, a patient presented with painless jaundice and abdominal bloating and new onset of diabetes. Those are somewhat concerning symptoms to be noticed. And so when they present it to either to their primary care physicians or in some cases to the emergency room, then in addition to physical exam and the blood work, most of those patients should have some sort of body imaging. So for that, we rely on CT or computed tomography, CAT scan. And so where would you take me next here?
Okay, so now we've got what would be the next step in establishing the diagnosis? So at this point, typically the gastroenterologist is often brought into the case before you get the call. Typically, we want to know for sure what we're dealing with, and also the patient has a blocked bile duct, and the gastroenterologist can go down through the stomach and out into the duodenum and put a stent to open up the blocked bile duct and also get a brushing or a biopsy. So the stent relieves the bile obstruction, so the jaundice goes away, and the biopsy is often then conclusive that it is pancreas cancer. So now we have established the diagnosis of pancreas cancer, and we've opened up the bile duct. And typically at that point, we bring the medical oncologist, the radiation oncologist, the surgical oncologist onto the team, and we present the case at the Multidisciplinary Cancer Conference.
Yeah, so for our audience, what Dr. Deming really just described is a tumor in the head of the pancreas, and that is where the confluence of the common bile duct and the pancreatic duct join together and empty into the duodenum, or the second portion of the duodenum. Depends on where you're from geographically and how you pronounce that. But that's really the enzymes of the pancreas, as well as the bile from the liver, is what really does the digestions of all the food that we eat. The stomach make the acid, and the stomach churns to break the food down, but the actual digestions is from the activated pancreatic enzymes. So when patients presented with this biliary obstructions and so forth, and obviously a CAT scan can help, shows whether there's a tumor and so forth. As you had mentioned, the first step is always to alleviate the bile duct, because if you don't, then patients can get, progress into liver failure, and that is, usually a terminal conditions. So once the bile duct is decompressed, and if we have a gastroenterologist that can do that, as well as doing endoscopic ultrasound evaluation of the tumor from the inside out, that's the preferred way, then we can get some tissue diagnosis to see what it is and what type of pancreatic cancer it is.
And the CAT scan can also be helpful in determining, has it spread from the head of the pancreas. So we've already established we've got a cancer in the head of the pancreas, it's adenocarcinoma, and the CAT scan gives us some feel to whether it has spread outside the pancreas, gone to the lymph nodes, spread into the liver. Also, a good CAT scan can tell you, the surgeon, is it abutting or involving any of the major blood vessels that go to not only the pancreas, but to the rest of the gut.
You're stealing my thunder here.
Okay. Well, take it away. So we're in tumor board. We're in tumor board right now. Okay, they're showing, I can see, look at the CAT scan. They're showing the CAT scan. What are you looking for in that CAT scan to determine whether this patient might benefit from a major surgery?
Yeah.
What are you looking at?
So if you don't mind, let me go back to the tissue diagnosis, because what patients also need to understand is that there are other type of pancreatic cancers. What we usually use the word pancreatic cancers is sort of encompassing for the most common types. About 94% of pancreatic cancer come from the exocrine cells of the pancreas, which we call the typical adenocarcinoma.
Yeah. And the exocrine cells are the ones that make the digestive enzymes.
The duct, the lining
Yeah,
of the
the
duct of
duct,
the
yeah.
pancreatic duct. Yes. So, so then, yes, if that's the diagnosis, then the next step we would need to do is staging. Now, as Dr. Deming alluded to, staging come in multiple forms for pancreas cancer. The way that we usually stage, so for all patients who has any form of cancer diagnosis, you always want to approach your doctors or your cancer specialist and say, okay, doc, so then what stage am I at? And we should be obligated to give patients that information or continue further workup until we have at least the best clinical stagings that we can provide
So
to
don't
them.
hold us in suspense.
Yeah.
How do you stage the patient?
We have 45 minutes, right? So
Not long enough to do the surgery.
So as you know, the staging is the T, N, and M, which is the tumor, the nodal, as well as the metastasis. Obviously, the tumor is looking at the size of the tumor as well as the blood vessel involvement within the area. And then the nodal status is whether any lymph nodes within the adjacent to that area, or perhaps even remote from that area that looks suspicious. And we use size criteria as well as some of the features of how it looks. And then obviously we look at the liver and the lungs and some of the other organs to see whether the cancer has spread to those areas or not. So that's the typical T and N and M staging system that we use according to the AJCC system. Now for surgeons, to your point here, once we determine that the cancer has not spread to remote area, then we would look specifically at the pancreatic tumor. In the head of the pancreas, there are, as we had mentioned before, there are many important critical structures that we need to either preserve or sometime resect it, but have a way of reconstructing in order for patients to be alive. So then we would look at the venous structures or the veins around that area, specifically the vein that drain all the blood flow from the intestine to the liver. We call that the portal mesenteric confluence or the portal mesenteric venous system. And when we also looking at the arterial sides or the arteries that bring blood flow from the heart to the aorta, and then that blood vessel will bring all the blood to the intestines. If those vascular structures are involved, and depends on how much involvement they are, then we would have our own staging system and determine what is the resectability of the tumor. So we have really three categories that we label based on multiple society definitions. One is resectable. So if the cancer is small, localized, and haven't really involved the vascular structures, then we would categorize that as upfront resectable. If the tumor starting to involve touching the blood vessels, the venous size, then we would categorize that as borderline resectable, meaning that potentially we can remove it. And then if the tumor heavily involve the vascular structures in that area to the point that we cannot remove it safely, then we would categorize that as anatomically unresectable. Now, in the category of unresectable tumor, we also break it down, whether it's anatomic reason, whether it's from metastasis, as I mentioned before, or actually whether it's because the patient's performance status.
So they had lots of hearts or lung disease that they may not be able to withstand the surgery.
The surgery, correct.
So that's one of the most important things of the tumor board is surgery going to be part of the patient's treatment? So if they're already metastatic, it's like, well, the cat's out of the bag. There's no sense putting them through a huge surgery to remove the pancreas tumor if the cancer's already spread. So then we move forward with chemotherapy as the mainstay. That first category, if it's localized to the head of the pancreas, there's no metastases in the lymph nodes that we can see. There's no involvement of the blood vessels. There's no metastases. Then we still have the option of, do we go right to surgery, or do we do some chemotherapy first and then follow it with surgery? That has changed over the course of time since I've been a doc at Mercy for 35 years. We used to, for those cases where there was not metastatic disease and it was resectable, always do surgery first and then figure out afterwards whether to do chemo or radiation. But more recently, there's data that shows perhaps improvement even in those resectable cases of giving some chemotherapy up front. Would you agree with that?
Yeah, so this is a debate that's still ongoing today, and I recently came back from a national meeting where this specific topic was up to debate among some of the national experts, whether patients who has resectable pancreatic cancer, is there a role for what we call neoadjuvant chemotherapy
And that word neoadjuvant means giving the chemo first and following it by
before
surgery, as opposed to adjuvant chemo, which would be surgery first followed by chemo.
Yeah, and there are things that can help us even tease out those informations, right? We want to treat, for all our audience, the doctors you go see should be the one that actually treat you specifically, not the cancer that you have. So by that, what I mean is that, individually, every patient should be unique in their own way. And so, yes, let's say Miss So-and-so or Mr. So-and-so has resectable pancreatic cancer, but does that mean that's all the story? I don't think so, right? So it means that we should look a little bit more and say, what in the cancer that would benefit more from going to surgery right away versus those that would say, wait a minute, let's maybe test it out, try it out, give those patients some chemotherapy so that way they can have more benefit than upfront surgery. And so one of the marker that we use is the bio tumor marker that's called the CA19-9. It's a Lewis antigen. Not everyone secrete that, but the majority of patients secrete that antigen, and we can use that to measure the amount of quote unquote tumor particles that are floating in the bloodstreams to tell us the tumor burden that the patient has. Or it's a symbol of micrometastases, because that's what pancreas is known for. So we use that information to sort of then help us stratify if the patient has a high CA19-9 tumor marker, even though the tumor, based on radiologic definitions, fit the resectable category. I would advise them, that the whole multidisciplinary care team to say, let's give these patients chemotherapy, let's restage them. Now, for our audience, most of the patients that come in and see me or, see any of us, we always want things done. We don't want delays. And I think that's a very fair and valid, point for all patients. But at the same time, for us, surgeons, surgical oncologists, we want to make sure the therapy that we deliver to patients give them the most bang for their buck. Because as you mentioned, the surgery, these type of surgery, are major surgery and does come with side effects and potentially consequences, right? So we want to.
Yeah.
Am I
No, I was just
talking
gonna.
too much?
No, you're good. I just wanted to bring us back. So, from the debate you
Yeah.
listened to at your conference, and from what you just said, I would infer that if the scan shows that the patient falls into resectable,
Hmm.
but they have a high CA 19.9, most people agree do chemo first and then do surgery.
Yeah.
Now, I'm inferring from what you said that if they have a resectable tumor on CAT scan and have a low 19.9, I don't want to put words in your mouth, but you might recommend they have surgery first in that case. Is that right?
Yeah. I think that's one way for us to help
Yeah.
stratify, treatment algorithm.
So
And I,
since you
yes,
are a surgical oncologist, I really want to get to you talking about what this surgery entails, because as you pointed out, this is a tumor in the soul of the body, and it's not just going in and plucking out, like pulling out a golf ball. You have to do a lot of reconstructing. You've got the duodenum, you got to remove some of the bile duct, you've got the pancreas, and you got then to put everything back together. So maybe describe a little bit about what it is you're going to remove and how you put the patient back together.
um, okay. So moving on to the patients in the operating room.
Okay.
Depends on the extent
And we
of
have an anesthesiologist and he's put the patient to sleep.
so depends on the extent of the cancer and the tumor. There are actually different ways to approach it. And recently, I have adopted and gained proficiency in doing the pancreatical duodenectomy surgery or resections of pancreatic head tumor using minimally invasive approach. So that is a consideration. And the approach that I use is that I use the robotic platform. And instead of cutting patients open, like we, have traditionally do or continues to do, what we have done is that we can usually make little incisions, dock the robot, and then I would control the robots to do the surgery. And by doing so, we minimize the morbidity or the problem that associated to the incision itself. And there are studies that have been done. The data is somewhat mature now. That there are studies that have been done to say that the minimally invasive approach is non-inferior to the open approach.
In
Okay,
terms of controlling the cancer, but much faster recovery time
better
for the
recovery.
patient.
Now, having said that, it can go either way. I think the key here is to have proficiency and and expertise in getting the surgery done, because the morbidity associated with this type of surgery is actually not from the incision itself, but it's actually from the reconstructions after the resection of
So
the
maybe we
tumor.
should throw in, for those people who might know the term Whipple operation is often associated with removing a pancreas cancer tumor. And I'm sure that there's a classic definition of Whipple by Dr. Whipple, but it's become synonymous with pancreas cancer surgery. Although, and no, Dr. Whipple was not doing robotic surgery. What are when you do a surgery for curative intent for a pancreas cancer in the head of the pancreas, what is it? What parts of the body do you have to remove, and which parts do you have to sew back together?
Yeah, so the classical definition that Dr. Whipple described and performed at Johns Hopkins, in the early, let's say, 19, 20th century. Okay, and I actually read his biography and came to admire, really the adventurous side of of him being a surgeon and so forth. But either way, the classical definition is that because the head of the pancreas localized in the around the duodenum or the duodenum, wrapping around the head of the pancreas, the bile duct, the pancreatic duct, entering into that area is the center of the digestive tract. So in order to remove that, we would have to disconnect it from the stomach. We would have to disconnect it from the proximal jejunum, or the proximal portion of the small intestine, or the jejunum, which is part of the small intestine. We would have to disconnect it off of the neck of the pancreas. We would have to be able to free it off from the portal mesenteric vein as well as the artery, and then we would have to cut the bile duct, and then to be able to remove this tumor. And obviously, there are oncologic definition on how to properly do it, to include the lymph nodes around in those areas. And once that's done, the surgery, in my opinion, should be divided in two phases. The first phase is the resection phase, or the removal phase. And then the second phase is the reconstruction phase.
So on the removal, how big is the specimen that comes out? And does it come out all as one piece? And is it the size of a plum, the size of an apple, size of a grapefruit?
Yeah, funny you mentioned that. Dr. Franko, or my partner and I, we often talk about this, because after we spend hours in surgery, it can be any ranging from 3 hours to 7 hours, depends on how tough the resection phase was. And once we remove it, it no more no less than the size of, I would say, maybe a give it some credit. I would say maybe if you
An
include,
orange?
if you can include the pancreas as well as the duodenum and the jejunum, I would say it's about a small grapefruit.
Okay.
Okay.
And it all comes out as one piece.
And it needs to come out in one piece.
Yes.
We don't do piecemeal resection,
Yeah.
especially for cancer
Yeah.
cases, right?
So it takes
So-
hours and hours to get that out, and then the real delicate work of reassembling
Reassemblance
begins, right?
But would usually, would kind of callously say that, we spend hours for this.
That's all I get.
Yeah, that's
is a
all you get,
grapefruit.
right?
So
So then moving on to the next phase, and I think that next phase, really determine patient's recovery.
Yeah.
Obviously, the resectional phase is important for the cancer side of things, but the reconstruction phase is how patients will recover afterward. And so then we would have to reconnect the intestines to the cut pancreas, reconnect it to the bile duct, as well as reconnect it to the stomach.
Mhm.
So over the year, the surgery has evolved where now we don't have to, in majority of the time, we don't have to cut a part of the stomach anymore. We can do something called a pylorus preserving pancreatic duodenectomy. And then we have also, evolved to doing really duodenosparing pancreatic pancreatectomy, although there's some controversy there. And then we have also evolved to, as I mentioned earlier, doing it in a minimally invasive way as well.
Mhm. And that minimally invasive you described is where you're using robots to assist it. So classically, with the open technique, how big is the incision across the abdomen? Is it a horizontal incision across the abdomen for an open Whipple resection?
We would
Or is
do
it a
it.
vertical?
We would do it in a vertical way
Vertical.
because it's not muscle splitting. If you think about it, the rectus muscle, or the muscle that we commonly think of as the six-pack muscle, goes, in a longitudinal direction. So if we go transversely, then
So
we
you go
would
right
cut
down
through
through the middle,
right.
so that all the patients could still have a good six-pack when they
Yeah.
get recovered.
And the incision should be, probably I would say 8 to 10 inches.
Mhm. And then if you do are able to do a minimally invasive robotic resection, how many incisions and where are the incisions located?
Yeah, that would be about 4 incisions. That's about half an inch to 1 inch in size across the abdomen, and one incisions that is below the belly button of about 2 to 3 inches in size, so we can extract the specimen afterward.
Okay. What part of that surgery is the most challenging?
Think the most challenging part of the surgery is, well, there's many parts. I think, as I mentioned to you one time, that's how we don't climb Mount Kilimanjaro. Doing the surgery is my way of climbing the Mount Kilimanjaro. Either way, joke aside, the thing that determine resectability is obviously the involvement of the blood vessels, and we are talking about major blood vessels. Any injury or problem with those blood vessels pretty much, lead to nothing good for patients. And so in order to free the tumor off of these blood vessels, we would have to have either a plan going in, or we would have to have a plan of controlling these blood vessels, cut them out at the same time to include with the pancreas, and find ways to reconstruct those blood vessels. And to do that, then it's really a multidisciplinary surgical team. So now we're switching gear from disciplinary cancer team to multidisciplinary surgical team to do things like that.
So you might have to have a vascular surgeon there.
We have a vascular surgeon
if you have
there.
To start reconnecting blood vessels.
Correct. And even, I would need, another trained surgeons there to help me. And even the vascular surgeons would need a trained surgeons for them to help them. So then we work as a team, but that's what it takes to get things done. And in my opinion, done correctly.
How long on average would an open Whipple resection take, and how long on average would a robotic resection take?
Yeah.
And by that, I mean the amount of time the patient's under anesthesia.
It really depends on the pathology. So it's pathology driven. I've done Whipples in 5 hours. I've done Whipples in 12 hours open. The average, national average, based on some data series, surgeons that publish fairly mature data, should be around 350 to 400 minutes for open. Okay. And initially, the data for minimally invasive Whipple surgery, as surgeons start doing them and gaining that learning curve, obviously the length of surgery goes longer. But as we gain proficiency and so forth, that length of time in surgery decrease. So now what have been shown is that, probably I would say on average, the minimally invasive way probably take about 30 minutes, maybe to an hour, longer than the open.
Yeah.
And I'm speaking on an average. Yeah.
So obviously what you described, Whipple surgeries are not done at small community rural hospitals, requires tremendous expertise, and there's a very limited number of hospitals that would be able to do Whipple resections in the state of Iowa.
And I agree to that.
Yeah.
Yes.
Yeah.
Yes.
High level of expertise, and as we mentioned, multidisciplinary
and care approach.
For those patients who get chemo first and then get surgery, what are the differences that you notice as a surgeon going in? Are the patients who have chemo, do they have special concerns in terms of the surgery? Sometimes they might end up being a little bit more malnourished or weakened because of all of the side effects of the chemotherapy, but sometimes the chemotherapy can shrink the tumor. Does that chemotherapy effect on the tumor make it easier to resect? Does it make it more difficult to reconnect? What have you found?
Yeah, so for patients who need neoadjuvant chemotherapy, obviously, our medical oncologists would stratify, depends on their health, depends on their comorbidities, which type of chemotherapy and which regimens and dosage, and how often they get chemotherapy. And then we would monitor those patients to determine, when is it the most optimal time to proceed with surgery. Um, Specifically for those patients, depends on how many cycle of chemotherapy they get. We would anticipate some of the known side effects that associate with chemo. One of the common side effects that I have seen is that anemia. And obviously, with anemia and then you patients going in for major surgery, it doesn't go well together. So that's something that we usually monitor for. When Whipple,
Speaking of anemia, it makes me think of a question. So in the typical Whipple resection, do patients usually require additional blood during surgery, blood transfusions? Or if things go well, would you say commonly they don't need to receive blood?
yeah, no, they should not.
Okay.
Yeah, they don't.
There's not enough
should
blood
not
loss in
receive-
the
no,
surgery to require a transfusion.
Correct.
Okay.
Correct. So, we have looked at our own series here, and I would say our average blood loss for a Whipple surgery probably range between 50 to 100 cc per case. So if you think about it, every time you go in to get your blood drawn for labs, test tubes, things like that, that's probably about 5 to 10 cc. So we're looking at maybe 10 of those test tubes, if that, to be the case. Obviously, that's the averages. I could only remember maybe once or twice where I may have to give blood transfusions in surgery. Yeah.
Where do you think we're going with pancreas cancer? You mentioned that the incidence of pancreas cancer, it's probably eighth in terms of the different cancers in terms of incidence, but it's very high in terms of mortality, which means that cancers like breast cancer and prostate cancer are very common, but much lower mortality or death rate because most people are successfully treated. But pancreas is kind of the opposite. How do you think we're going to make progress in pancreas cancer specifically?
Excellent questions. I think obviously is early detections would be the area that I think needs to have research and further investigation. So let's switch role here. Why don't I be the host?
Okay.
And you're my guest today, okay? Because, recently I attended the MercyOne GI annual conference.
Mhm.
And you gave a beautiful presentations on early cancer detection. So can you please enlighten me and the audience on what that's about?
Well, thank you for asking. There is a new test that has been verified scientifically to be able to find 50 different types of cancer at an early stage. And they're called multi-cancer early detection blood tests. And I said that slowly because everybody likes acronyms, and the acronym that is being used for these tests is MCED. Again, multi-cancer early detection. So it's a blood test that can find circulating tumor DNA that has been released from cancer cells that have died. So we're not finding in the bloodstream cancer cells, we're finding the DNA from cancer cells. And even early stage cancers, cells will naturally die. And when they die, they release the contents of the cell into the bloodstream. And we have the scientific ability to find DNA circulating in the bloodstream, and we can specify that it is cancer DNA, and we know where it's come from. So we actually shared a case where a patient had no symptoms, had this blood test done. The blood test said, we find DNA from cancer, and it looks like it came from the pancreas. And lo and behold, did a CAT scan and found an early stage pancreas cancer. And the patient is now 2 years out without recurrence. So that technology, the early detection blood test, can discover cancers that we previously had no screening test for. So we're excited about that. We don't know whether we'll still find all of the pancreas cancers at an early stage. One of the problems with pancreas cancer is it can metastasize early. And so some of the reason that we don't cure more patients is that even when you take out the primary tumor, lo and behold, over time you find that cancer cells were hiding elsewhere in the body. So I think the second exciting change will come when we get more effective systemic treatment, whether it's chemotherapy, sort of old-fashioned drugs that kill cells that are undergoing mitosis, or whether it's a newer immunotherapy that stimulates the body's own immune system to fight the cancer, or in some cases, targeted therapies that have been specifically designed for a particular protein marker or mutation within the cancer cell.
Or a combination of those.
Yes.
So the sequence and the regimen combinations will also, give us a lot of possibility. But let's go back to this. I'm very intrigued about this multi-cancer early detection test. So if it sounds that good, should we all go and get one?
So there's some downsides. So if you test just the general population at age 50, on average, 98% of the time the test will be negative. No cancer DNA found. 2% of the cases will be positive, and then you have to start looking for the cancer. But of the 2 that are positive, you only find the cancer in 1 of the 2. So one of the downsides is you may have a positive test. You're told, we think you have cancer, and then you can't find the cancer. That can be very distressing.
So, and why do you think that is? Is it because the test is too sensitive that it picked up the cancer before the imaging can even show it? Or is it because the test has some faulty mechanism that gave off the false alarm?
Both of those come into play. If you don't find the cancer, you repeat the test. Half the time the test is going to be negative the second time. So probably the first one was a false positive. But the second can also be true, that the cancer is there, but the imaging and endoscopy just doesn't find it. And when you repeat those studies 6 months later, you may find it. So both of the explanations you gave do in fact factor into this. Sometimes it was really a false positive, and sometimes you just didn't find it.
Yeah, because, going back to pancreas cancer and all apply to other solid tumors, that, what we know from the cancer, the carcinogenesis model, especially for pancreas cancers, that, it usually exists in a pre-malignant state where there have been some form of genomic mutations that had occurred to put the cells in a pre-malignant state. And that can go on for years before it become invasive cancer. But as you're right, the moment the pancreas cell become invasive cancers, it only take about a year for it to really metastasize, where patients can go from stage 1 to stage 4. And oftentimes patients, depends on the location of the tumor in the pancreas that dictate what symptoms they present. So then going back to your your test, or the multi-cancer early detection test, where have they shown that the positive was actually picking up the pre-malignant state of the cancer? Has that been demonstrated?
Yeah, I would say that it doesn't. That the test is more effective at picking up more virulent types of cancers, and even a really well differentiated prostate cancer or really well differentiated, well behaved breast cancer is less likely to be picked up on the multi-cancer early detection. So it is more likely cells that are truly invasive and that are undergoing mitosis more frequently that will have the cell death apoptosis to release the DNA. And that's really what you would like. As if you were to do the test and you find all sorts of cancers that would never cause a health problem, you're really going to be providing probably more harm than benefit. So the test is the science of finding the cells has already been proven. What we haven't shown yet, and there are tests being done now, trials being done. In fact, the entire country of England is undergoing a clinical trial because they have a national health service. So one of the companies is partnered with them, and all of the population at age 50 is getting this test, and we'll be able to see for a screening test to be truly valuable, you have to not only find the cancer, but you have to show that by doing the test, you actually reduce the mortality or the death rate by screening a population, because you're not just screening patients who have symptoms. By definition, a screening test, you're screening patients who don't have symptoms.
Yeah, I think, obviously there's many factors to consider from an epidemiology standpoint as far as a screening test involved. For pancreas cancer, back in the 80s, there was a national study using that tumor marker, CA19-9s, as a screening test. But from an epidemiology standpoint, it just didn't make sense. It didn't work. So,
I'm going to steal the host microphone back because we have less than 10 minutes left. Okay. And we always like to open it up for questions. So we have a live studio audience. They get first dibs on questions. If you're watching us live streaming, please put your questions in the comments section of the software program you're using to watch us this evening. So first up, Poon.
Doctor, is there foods that you would recommend that people eat to avoid pancreatic cancer?
How can we avoid pancreas cancer? Not just foods, but anything. What can we do to avoid pancreas cancer?
Yeah, some of the risk factors that have been associated to pancreas cancer, and again, this is an association, not really causative. So just, be careful with that. But some of the risk factors are obesity, smoking, diabetes, and obviously genetic conditions that would be causations. But as far as I know, there's no really food type or food group that would link or associated to pancreas cancer. So you are good to eat whatever you want to eat. Obviously eat healthy.
What about viruses? We know that hepatitis increases the risk of liver cancer. Does pancreatitis increase the risk of pancreas cancer?
I think there are some studies to show mild associations, but I don't think that ever really pan out.
Okay.
But obviously, any condition that causes chronic inflammations would put you at higher risk for malignancy.
And Poon, your question reminds me, decades ago, there was a study that associated coffee drinking with pancreas cancer. And for several years, there was a big concern. That has been totally debunked. And there's no increased risk of pancreas cancer with drinking coffee. In fact, drinking coffee is a health food and actually reduces the risk of colon cancer and reduces the risk of all sorts of other diseases. So, but there was a time 25 years ago where that was something that was being floated as a possible cause. One of the causes that I'm concerned about is the possibility of environmental exposure. So not just Agent Orange from Vietnam, but we in modern life are exposed to thousands of chemicals, whether they're plastics and PFAS and food dye, or pesticides, herbicides, insecticides, and fertilizers, So it took decades to prove that cigarette smoking caused lung cancer. It may never be able to show which of the 1,000 chemicals we're exposed to causes dozens of different cancers. Other questions? Yes, Tim.
Oh my, after what I heard tonight, I do not want to get pancreatic cancer.
Yes.
It just sounds so extreme. But having said that, out of the patients that you do treat via surgery, What is about the average age of a person who would have pancreatic cancer where surgery is needed? What's about the average age?
Yeah, the median age of diagnosis for patients with pancreatic cancer is about 70 years of age. So I would say between 60 to 70, that would be the average age of diagnosis.
Kevin, do you have a question?
So would you recommend that people that have these associative characteristics might see about the possibility of an early cancer detection blood test? Or is it just too many of those people to throw it out?
Yeah, I think you also have to consider obviously your own personal risk factors, as you mentioned. And then also, what are the financial side of it? Is this test being covered by the insurance company or not?
Right now, it's not covered by insurance, and it costs $949. So that is the typical cost for doing the test. We do believe that once the studies, especially the one in the United Kingdom, gets completed and it shows that it is a valid screening test and it saves lives, it will be incorporated as screening. Right now, we have 5 cancers that there are valid screening tests for. We have lung cancer for smokers. There's a CAT scan that can be done for screening. For breast cancer, there's mammography. For colon cancer, there's colonoscopy or blood or stool testing. For cervix cancer, there's pap smears. And for prostate cancer, there's a blood test. Right now, those are the 5 valid ones. If this other one becomes valid, it will initially start that it will be done along with the other 5 screening. But there could, over the next 10 years, we could learn that maybe the blood test ends up being a better screening, and that we use the imaging more to find the cancer. But right now, the thought is that this multi-cancer early detection screening test would be in addition to the 5 conventional screening tests.
Yeah, the other thing I want to add here too is, I think, and I'm going to play devil advocate here, is that with screening tests, obviously you need to have the right number of efficacy. So it has to have a certain accuracy rate in order for it to be useful. Because if it's not, and it can lead to a lot of distress, anxiety, but not only that, consumptions of healthcare resources, right? While we are essentially chasing something that may not be there. And obviously patients factors one issues, but then what about other patients that need that healthcare resource? And are we overspending into something that, may not be as fruitful?
Yep.
So that would be another flip side to that.
George, you get the last question. Do you have a question?
Yeah, just a quick question. There's a lot of news coverage about the soaring cancer rates in Iowa, and they're searching for the cause. One of the things that we're a leader in, and not proudly so in Iowa, is the use of methamphetamine. And I've always heard that meth is very hard on the pancreas. Is there any chance that meth use increases cancer of the pancreas?
I think not that I'm aware of. I think I'm glad you brought up the point of the soaring rate of cancer diagnosis here in Iowa, and I believe we are the second highest state in the country in terms of cancer rate. As far as the use of methamphetamine, I don't know any data to really prove that or the other. I'm sure other states, in as much as I hate to say it, I'm sure that problem occur in other states as well. But having said that, though, I do know that the University of Iowa is actually engaging in active investigation and research into this specific topic, not related to the methamphetamine part, but why is it here in Iowa that cancer rate is increasing. And I think you had mentioned that one time was that maybe environmental exposures and factors. So if you please enlighten me on that.
Yes, well, if you would like, 3 weeks ago we did a whole topic on cancer in Iowa, and so I'll send you the link so you can watch. You can watch my rerun.
Touche.
And I'll watch
Touche.
the rerun.
Yeah.
So our guest tonight has been Dr. Viet Le, a surgical oncologist at MercyOne Cancer Center. Thank you for being with us.
Oh, my pleasure.
And if anyone watching this live knows someone that would benefit by watching it, we will be on reruns. We will be available on demand beginning tomorrow at the Above and Beyond Cancer YouTube channel and the Mercy Cancer Center website. I hope you'll join us again next week. Thanks, everyone.